Good evening, everyone. A warm welcome to all the faculty and delegates for this webinar called as Vivaadham. This is the fourth episode that we are doing, and we from the Obstetrics and Gynecological Society of Southern India, myself, Dr. Karpagambal Sairam, the executive committee member, and Dr. Vijaya, who's also a coordinator for this webinar, warmly welcome you for this topic called as mesh in urogynecology. We know we have come a long way in clinical practice. A lot of PSIs keep saying change is the only constant thing. We have been using mesh in urogynecology for a long time, but now there are a lot of restrictions on the use of mesh in urogynecology. So to actually give us a beautiful insight about the whole thing and give us clarity in clinical concepts, we have this webinar, and I welcome all the faculty and delegate once again. Next slide. Professor Sampath Kumari, Madam is our president. Madam is unable to join because she is in US on a holiday. She'll be back next week. And because of that, I request Dr. Meena, who's our secretary, to give the welcome address.
Thank you, Dr. Karpagam. So, like to extend a warm welcome on behalf of the Obstetric Gynec Society of Southern India, as already told by Dr. Karpagambal Sairam. This is a fourth Vivaadham webinar series, and this will be a very, very interesting topic. Mesh is a mess or use. So, we would like to welcome our Medical Education Committee Chair, Dr. S. Vijaya Ma'am, and Dr. Karpagambal Sairam, who is the co-chair. And also like to welcome Dr. Rahavi, our own MMC student and now a consultant at Madurai, and Dr. Mohini Agarwal and Dr. Monica Gupta for our webinar series on Vivaadham, and all our delegates who are part.
Meena?
I think ma'am was driving.
Yeah, I think she is driving. Yeah. Anyway, thank you once again, all of you. On behalf of Meena, I would like to take over and let her join. Once she joins, she will be able to give her inputs. So, Chitrakala, can we have the Oxy prayer? We have this Oxy prayer, which we say before all our webinars and meetings. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of a new life in a mom reborn, to the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you. Vijaya Madam, I'm not sure if Vijaya Madam is joined. Is able to join? Okay. Next slide. I think both of us are having some connectivity issue. We'll go ahead with the first speaker topic. I know Dr. Meena is a urogynecologist. I'm sure she'll be looking forward to this topic. It's very close to her heart. Dr. Raghavi, I welcome Dr. Raghavi. Raghavi is a consultant urogynecologist, Apollo Specialty Hospitals, Madurai. She is our own student from, she did MS from Institute of Obstetrics and Gynecology, Madras Medical College, and DNB from there, and she's an MRCOG degree holder, postdoctoral fellowship in urogynecology at KIMS Hyderabad, Arshal training at Cambridge University Hospitals, NHS UK. She has a lot of affiliations, and Raghavi, we are really expecting a clear conceptual understanding of the mesh your way and your experiences. Go ahead.
Thank you, ma'am. Talking at an Oxy webinar is like coming back home. All my first presentations, first posters, everything has been at Oxy. So I'm glad that I could have this opportunity to present here. So mesh in urogynecology. Mesh has always been a matter of controversy, rather because of the so many legal issues associated with it. So basically, why mesh? Before we go into it, why do we need mesh and what do we use it for? We know, I'll do a short recap on how prolapse or incontinence occurs. As we know, this is the boat in the dog theory where water is used analogous to our levator plate, while the mooring ropes are going to be the ligaments, especially the uterosacrals, which keep the pelvic organs, especially the uterus, in place. So whenever there is a deficiency of the pelvic floor, that is the levator plate, there is going to be additional strain on the ligaments, which is going to weaken and cause pelvic organs to prolapse. So basically, what is required is a reinforcement of the levator plate, its attachment, to prevent or treat prolapse. Similarly, when it comes to stress urinary incontinence, there are multiple theories I accept. But basically, what everything says is, when we take in the integral theory, it simply says whenever there is a disrupted muscle, excuse me. Okay. Whenever there is any disruption in the coordination between the muscles and the ligaments, there is going to be funneling of the proximal urethra, leading to leakage on increased abdominal pressure. In the same way, Delancey's hammock theory says the same thing. The hammock formed by the anterior vaginal wall is going to support the urethra whenever there is an increase in intra-abdominal pressure, causing compression of the urethra, preventing urinary leakage. Any damage to the support, that is the attachment of vagina to the arcus tenus fascia pelvis and the hammock, is going to lead to SUI. So the treatment should actually help to reinforce or restore the support. So how can we do this? So surgical repair for prolapse, as we know, includes native tissue repair, synthetic meshes, or biologic grafts. So we'll take it one by one. So mesh. Mesh can be of various types. Basically, what we need to know is meshes are classified based on whether they are monofilament, the size of their pores, and the surface area and the weight. So what is important is, if it is multifilament, then there is increased chances that the bacteria lodge in between the filaments, leading to infection. If it is microporous, again, bacteria can invade while macrophages and neutrophils cannot, leading to increased chance of infection. And also in microporous meshes, there is a phenomena called bridging fibrosis, wherein the fibrosis occurring between the adjacent pores join together to lead to thickened fibrosis and increased pain. So what we actually need for vaginal mesh is something which has a large pore size, which is lightweight, so that there is increased vascular penetration and ingrowth of tissue with reduced fibrosis and encapsulation. So right now, to put it simply, type 1 monofilament macroporous meshes are the only ones that are used for our prolapse repair or incontinence repairs, while the type 2 and 3 meshes previously that were used, the Gore-Tex, etc., are currently not available and are withdrawn from the market. So when we go on to, if not synthetic meshes, why not biologic grafts? Well, for biologic graft, they have their own advantages and disadvantages. One, we have autografts. Autografts is when we harvest the patient's own tissue and use it to reinforce the repair. So for example, we use the rectus fascia, the fascia lata for SUI repairs. But again, the advantage is, one, it is the patient's own tissue, and the disadvantage is the same because it is her tissue and the strength of the tissue varies between patient to patient, and so does the surgical results. Secondly, the harvest site undergoes scarring and there is associated morbidity with the healing and scarring of that site. So if not from the same patient, why not from a cadaver? The cadaveric allografts are also available, but again, in India, we do not have licensed cadaveric grafts available, and they come with their own problems of graft rejection. And again, the tensile strength of the graft it cannot be standardized. So the tensile strength varies between each product. So again, the results will vary or variable. So if not from cadavers, from other animals like porcine or bovine dermis, their intestinal submucous and urinary bladder matrix can be used. These are acellular, so graft rejection chances are less, but again, their availability is limited. So why do we need synthetic meshes? One, native tissue repairs based on all studies show that they have a 40% failure rate at the second year post-operative visit. So therefore, using a graft makes the repair more durable, especially whenever there is defect in the apical or anterior compartment, and it helps to restore a better vaginal anatomy. And synthetic mesh of anterior wall prolapse, where recurrence is most common, improves the anatomic outcomes and bulk symptoms when compared to native tissue. On the other hand, studies have shown that biologic grafts do not improve prolapse repair outcomes in any compartment. They are equivalent to native tissue repair only. So currently, where do we use them? We use mesh, as we know, for SUI treatment and for the prolapse. In stress urinary incontinence, mesh is used as a tension-free vaginal tape or transobturator tape, that is the mid-urethral slings. We have single incision slings and readjustable slings also. All of this have this in common. They use only type 1 polypropylene meshes. So TVT, as we know, we are going to place the mesh in the retropubic space in the form of a sling at the level of the mid-urethra. This is a self-fixing tape. We do not have to fix at the exit point. And the methodology of introducing the needle can be from down up. That is, we make an incision over the anterior vaginal wall, introduce the needle, and the exit point is about 2 centimeters above the pubic symphysis. Again, we tension it we leave it tension free. We don't tighten it. So it is a tension free. How does it work is whenever there is an increased abdominal stress, it causes kinking of the urethra around the mesh, thereby preventing leak. The other type is the transobturator sling. This is again the type 1 polypropylene mesh. You can see that the mesh is like a ribbon, like a satin ribbon that we use. And here the mesh is placed a bit more horizontally, and the entry and exit points are through the obturator foramen, that is, and the skin exit point is at the groin region. So it is much more horizontal, and the chance of bladder and urethral injury is lesser when it comes to TOT. So basically, what are the problems with using mesh here is, apart from the mesh complications, the chances of injury to the bladder is about 5% in a TVT or retropubic approach, which is very less, about 0.6 in a transobturator approach. So usually we do a cystoscopy after each needle pass when we do a transvaginal tape or retropubic tape. Chance of urethral injury is very rare. Some can have voiding dysfunction, while vascular injury, especially to the epigastric vessels, accessory obturators, can occur but is very rare. With the mesh exit points, there is chance of pain. And however, overall sexual function does improve when the patient is cured of a stress urinary incontinence. But yes, dyspareunia has been reported. So the chance of vaginal mesh exposure with this meshes, the 10-year cumulative risk rate is about 5.3%. So how do we choose which one to use? Is in the short term, both are equally curative, but in long term, we prefer TVT to TOT. And however, TVT has a bit steeper learning curve than TOT. So the current recommendation is for primary surgery in hypermobile urethra in any age group, we go for transobturator tape. For recurrent or persistent SUI with again hypermobile urethra, we go for TVT. Beware that in intrinsic sphincter deficiency, these mid-urethral slings are not much effective, and we have to go for much more obstructive surgeries like a pubovaginal sling, where we use the patient's own biological grafts, that is their fascia lata or the rectus fascia. So now, because of the groin pain and other issues, there are single incision slings where there are no exit incision. We just do the anterior vaginal wall incision and place the slings, and they get fixed to the obturator membrane, currently not available in market. And the newer one is the readjustable sling, which is much more smaller. The amount of mesh used is much more smaller, and the advantage is this is placed retropubically, but the tensioning is not done. Based on the patient's degree of SUI, we can do the adjustment throughout our life, because we place this sling below the urethra, and this part, which looks like a knob, is placed at the end of the circular part is placed at the level of rectus muscle, while this knob is removable and it is used to tighten the sling based on the patient's symptoms. This is Remix. Again, it is available in US currently, and post-market studies are undergoing for this. So what about prolapse? Prolapse, as you know, we have abdominal prolapse repairs and vaginal. For abdominal, we have sacrohysteropexy, wherein we fix whenever there is the uterus. In sacrocolpopexy, in a patient has undergone hysterectomy. And if there is additional defects, even sacrocolpoperineopexy can be done. All of this are simple in that we are going to suspend the vaginal apex, or if the uterus is there, the uterine cervix, using a bridge to the anterior longitudinal ligament just below and distal to the sacral promontory. Here again, the type 1 polypropylene mesh is used. There are no ready-made mesh kits available for this. We fashion the mesh, like we take a routine Prolin mesh and then we fashion it based on the patient's requirement into a Y shape and then tack it to the sacrum and bring the other end. If it is a sacrohysteropexy, it is like hugging the uterus from behind and then we take the stitch over the anterior part of the cervix. If it is sacrocolpopexy, what we do is we fix one end, tack it with a bone tacker, or you can use ethibond sutures to the anterior longitudinal ligament, and the remaining part of the Y, the two arms of the Y, are placed in at the vaginal apex anteriorly and posteriorly after dissecting off the bladder as well as the rectum. So studies show that sacrocolpopexy is associated with a lower risk of prolapse awareness, recurrent prolapse on examination, repeat surgery for prolapse, and postoperative SUI and dyspareunia when compared with a vaginal prolapse repair, either with or without mesh. So basically what they mean is sacrocolpopexy is gold standard when it comes to reduced recurrence, reduced patient symptoms, including postoperative stress urinary incontinence. So, but the problems is it has quite a steep learning curve and it is preferably done in a minimally invasive manner, like using laparoscopy or robotic rather than an open procedure. And the chance of visceral injury is rare, but it is devastating. So what we currently recommend is the ICI consensus on decision making for prolapse. What it recommends is for a post-hysterectomy vault prolapse in younger individual, a severe prolapse or shorter vaginal length, we can preferably go for a sacrocolpopexy, even though vaginal repairs are equally good depending when the patient is chosen correctly. So the problems, as we know, the chance of bowel injury, bladder injury, especially ureteric injury, does exist. And hemorrhage is rare, but when it occurs in a sacrocolpopexy, can be devastating, especially when we injure the presacral plexus of veins. Actually, we have to immediately either seal it, or sometimes even we need to use tackers over the bleeding point, because the presacral plexus, the veins can retract and go into the sacral foramina, leading to lots of complications. Postoperatively, chance of spontaneous bowel obstruction is a bit more higher because it is an abdominal procedure. Very rarely there is sacral osteomyelitis, and then comes the mesh exposure, which is always the problem with all of the mesh surgeries. But however, studies have shown that preserving the uterus or doing a subtotal hysterectomy reduces the chance of mesh exposure. But however, with abdominal mesh repairs, the chance of mesh exposure is still lower than in vaginal repairs. So going on to vaginal prolapse repairs. So for vaginal prolapse repairs, we can use a self-tailored mesh where we fashion the mesh based on the patient's degree of prolapse and the size required. Then there were the trocar guided mesh kits, which can have either which are usually brought out through the trans operator via needles, or we have the transvaginal mesh kits. So advantages of using a transvaginal mesh. This is a recent Cochrane review by Young et al. Published in 2024. So this compared transvaginal mesh or grafts or native tissue repair for vaginal prolapse, and these were their conclusion. Awareness of prolapse at 6 months to 7 years was less likely after mesh repair, expected. Rate of repeat surgery for the sake of prolapse was lower in mesh. But however, more women in the mesh group still require repeat surgery for the combined outcome of mesh exposure or incontinence or prolapse. There is no difference in the groups for repeat surgery for incontinence, and vaginal mesh exposure was around 11.8%, and of which 6.1 had to undergo a resurgery. There was no difference in the rates of dyspareunia. So, however, even though there are lots of points against mesh, what retrospective studies have revealed is this study by Cundiff et al. Showed that when FDA revoked the mesh usage, most of the patients who had complications, especially even with abdominal sacrocolpopexy, appropriate mesh was not chosen because they were using the Gore-Tex mesh, which is a type 2 polytetrafluoroethylene mesh and has more chances of mesh exposure. So appropriate material selection is very vital for decreasing the risk of mesh-related complications. And secondly, within the framework of transvaginal mesh related litigation cases, only 12% of the surgeries were done by board certified surgeons. That is, a prior prevalence of inadequate expertise was there in the TVM application, which might be a reason for the mesh related complications as well. So these are the commonly used meshes which were available in the market for transvaginal repairs. This is the Elevate, which is which is fixed to the sacrospinous ligament and to the arcus senis fascia pelvis via sutures. And these were the apogee and perigee meshes where they used needles to bring it out. For example, this apogee is for the rectal and apical failures, where the one end of the mesh was fixed to the two ends were fixed to the arcus tenos fascia pelvis, and the other, if required, was to the sacrospinous ligament, and needles were used to bring out the mesh. So it was easier for learning was easy. It did not require much expertise. The learning curve was shorter. Similarly, perigee was used for anterior repairs or anterior cystoceles, none of which are currently available in the market. Right now, for transvaginal mesh repair, it is considered off-label use of meshes, and we do not have any pre-made or tailored mesh kits. If we want to use a mesh, it should be self-tailored. Usually, what is suggested is we can make a trapezoid mesh and use it accordingly for anterior or posterior repair as required. Be careful in patient selection, because in an irradiated tissue or an immunocompromised woman, say for example a diabetic who has issues with the wound healing, then the chance of mesh exposure and erosion is going to be quite high. So to prevent that, dissection should be deeper. Like when we are routinely doing a prolapse repair, we take the vaginal wall or vaginal mucosa as thin as possible so that we have more tissues to plicate or reinforce. But when you're putting a mesh, even for an SUI or for mesh repair of prolapse, make sure you have a thick vaginal mucosa or vaginal wall, and make sure the dissection is further lateral so that you can fix the mesh via sutures to the arcus senis fascia pelvis. And mesh can be used for recurrent cases with an informed consent from the patient after a proper discussion of pros and cons, and the surgeon should have expertise in managing the complications that might arise because of the mesh. So basically, right now, there are various consensus on whether to use or not use, but the European Urology Association, the European Urogynecological Association, and OX have issued positive statements endorsing the use of transvaginal meshes for incontinence and prolapse. Actually, what they state is TVM repair or transvaginal mesh repair remains a crucial treatment option for POP. But however, to conclude, right now, the FDA permits the use of only mesh for only two purposes. One is the multi-incision slings for SUI, that is your mid-urethral slings. This is endorsed by other bodies as well, like OGS, the International Urogyne Association, the Society of Urodynamics, SUFU, the ACUG. Everyone have established the safety and effectiveness of slings. So hence it is used. And for abdominal procedures, synthetic mesh, sacrocolpopexy. So synthetic mesh used in sacrocolpopexy procedures is the only indicated mesh for prolapse repair, as it results in fewer recurrence rates and less mesh-related complications. See, in abdominal mesh repair, the mesh-related complication was about 4%. On the other hand, the mesh-related complications with transvaginal was around 11.3%. However, when it comes to UK, final recommendations are still pending, and there is still restriction for use of mesh even for SEA procedures in the Europe and United Kingdom. So currently, FDA, based on its 522 post-market studies, has shown that the meshes that I showed you earlier, the Elevate, the ProLift, etc., are the 2024 and 2022 results of these studies, where FDA monitored the patients who underwent these repairs for over 3 years and showed that the results were equivalent and not superior to native tissue repair, and the chance of mesh-related complications was high. So right now, FDA allows usage of only abdominal sacrocolpopexy meshes and mid-urethral slings, including the mini slings or single incision slings for SUI, while the usage of transvaginal mesh repair is to be individualized based on the patient requirements and the expertise of the treating surgeon. Thank you. Any questions?
Hi, Ragini.
Thank you,
Raghavi.
Dr. Raghavi. Hi, Vijay madam has joined.
I called Priya and got the separate link. This Chitrakala didn't help me. What is it? I tried for more than half an hour, and Meena also called me. And finally, I called Priya because I wanted to listen to Raghavi. Raghavi is my student, and
I spent all my PG life with Vijaya ma'am.
so I just wanted to listen because this mesh is a controversial thing, and more so for the wall prolapse. That is why I really wanted to listen to this. And I hope Monica ma'am's speech, and after that, we'll come back to Raghavi, isn't it, Karpagam?
Next is Dr. Mohini Agarwal's speech, madam. You can introduce her. Chitra,
Okay.
next slide.
Yeah, no issue. Even chat box, they can put any questions they have, no? Yeah, Dr. Mogini, this is Dr. Vijaya from Oxy, past president.
Thank you, ma'am. Good evening, ma'am.
Thank you. And Dr. Mogini is a director and senior consultant Urogynec and pelvic healthcare clinic, Bathinda. And she is MS DNBOG and fellowship in Urogynec and reconstructive surgery in AIMS, New Delhi. Special interest in Urogynec, menopause, geriatric health and pelvic pain. Lots of contribution. Member of the fellow trainee of Ayuga, educational YouTube channel, Urogynecology, pelvic healthcare, international and national publications, and other chapters on urogynecology in various books. And now the stage is yours, and she'll be talking on against mesh. Yeah, let's listen.
Mesh.
Yeah.
The screen is visible, I think.
Yes, Dr. Mohini. You can make it full screen. Yeah. Slideshow. Yeah.
Good evening, everyone. Thank you, Oxy, for this opportunity. I thank my mentors, Professor J.B. Sharma sir and Rajesh Kumari ma'am, which have trained from AIMS Delhi. So my topic is mesh. Have they become extinct? And according to me, also we have never seen mesh used in vaginal surgeries. So I also thought this topic is actually a debate. Mesh is a mess. You sir used to say, J.B. Sharma sir. So when I got this topic, I read a lot about this, and actually, it is not has been extinct. It is much in demand. It is much in use, and how to use it and how to proceed. What are the studies? We'll see it further. So my work has been done a lot easier by Dr. Raghavi. She has explained all about the types of mesh and the ideal mesh which should be used. So I'm skipping this. So now this is one of the recent study, 10 months back in November 2024, long-term subjective efficacy of female stress urinary incontinence with tension-free vaginal tape, the obturator technique. So what they did is uh, the comparison follow-up rate was duration was from 10 to 16 year. It is the longest studied the article duration for the follow-up. As we all know, for SUI, current gold standard is tension-free transvaginal tape. TVT is the standard gold standard. So they have for very less complication rate, most efficacies of this surgery, because SUI, we know there are various surgeries by which we can improve the quality of patient who are having stress urinary incontinence. So they have found it very good. So yes, mesh basically we have three categories for the mesh to understand it simple. One, it is used for prolapse. The route may be abdominal or vaginal. In abdominal, we go with laparoscopically or robotically. And vaginal, the prolapse mesh which you use like Apogee and Perigee, which is not available in market for now. And another mesh is for the SUI surgeries, that is mid-urethral sling, stress urinary incontinence. But we all know this mesh for stress urinary incontinence is not bad. It is being used. Yes, in some part of the world, it is restricted and not in use. But as such, it is not bad. That mesh is still used. That is the gold standard treatment. So again, this is one of the study. Impact of single incision sling placement on female sexual function in women with stress urinary incontinence. As we in the last lecture we saw, dyspareunia is a complication with mesh TVT when we use it. But in this study, what they specifically studied was single incision, the mini sling, because the length of the mesh is shortened. So what they found is the females who had the sexual function dysfunction, it either remained the same or it has improved with time while they use the mini sling, that is single incision sling. So here, what the inference is that if the mesh, whatever it is, just not about the use of mesh, it's about even the length of mesh and the anchoring points. It should be biocompatible. So if it's used, then it can be has a better result. Again, one of the studies in March 2025, the tension-free vaginal tape versus polyacrylamide hydrogel bulking agent for stress urinary incontinence, the patient preference and outcomes in Finland. The study was done. So in this, the tape was used was Ethicon Johnson and Johnson, the TVT tape, and they gave the patient the preference to use whatever choice. The cost effectiveness, the staying, the complication rate, and the efficacy. The everything was better with TVT tension-free vaginal tape. In the case of 2021 patients who opted for TVT tape by preference for opting this method of choice for improving their stress urinary incontinence, 4 patients has mesh erosion, of which 2 needed the preventive intervention, re-operation, 2 need the loosening of the tape because it was too tight. So basically they found out this is a bulking agent. We all know that reinsertion again is a task with that the cost is increased, repeated hospital visit. So they found that tension-free vaginal tape with due complication they are having, but the significant was tension-free was the better way. So now coming the second part with the mesh, just as I said, there is no doubt that mesh for mid-urethral sling is used. Now the controversy, mesh is a mess, it all comes when we talk about the prolapse. For that also both in the abdominal procedures and the vaginally. If we go abdominally, it can be laparoscopically and robotically. And so this is the one from the Jan 2025 pelvic organ prolapse repair using robotic assisted sacral hysterocolpopexy versus vaginal surgery with uphold system, that is 1 year clinical outcome. So they have nearly equal patients were studied. The study was done in Sweden, and the mesh they used in uphold, which is not available even there for the commercial purposes. They did it only for the study. It is not available commercially even there in the Sweden. It was studied. So what they found when the mesh was done as with a robotic and as compared to the vaginal, the uphold, which is the monofilament, macroporous, lightweight mesh which was used, uh, robotic procedures who underwent, they have the higher re-operation prolapse rate. They have higher recurrence of the prolapse and they require the re-operation more that as compared with the vaginal. So the same, the FDA warning in which 2019 FDA has banned use of mesh. So again, again the same thing gets questioned up. Is it really trivial? Is this the really the reason was for the ban? Are we really doing that? Because the surgeon experience in this, the 3 surgeons were taken for the robotic who had the experience of at least more than 25 surgeries they have performed, and this was done. So this is the complication rate. So we can see that the very last one, the prolapse reoperation, were the more for the robotic than for the uphold vaginally when they did. Obviously, the urinary infection rate was more in the vaginal, yes, but it can be managed conservatively. Otherwise, all the complications rate were equal or more in the robotic assisted. So this is what the recent study. So by this conclusion comes that vaginal mesh has a better. Again, in this, it's about the technique also. They again went through the anterior midline incision, and the mesh has the arms which were fixed to the sacrospinous bilaterally with the KPO device. And in the robotic one, they fixed it same the standard procedure anterior and posterior and with the sacral promontory. So this is the study done in that Taiwan. This is also a recent 2024 study. Predictor of surgical failure following transvaginal mesh repair using minimally invasive prolapse system device. This is a study done in the Taiwan, which they use the mesh which is made from the Spain. And as we already seen, European Urology, Urogyney Association, European Institute of Urology, Association of Urology, Germany, Austria, this does not contradict ban the use of mesh. So in this, what they did use is ultra light, 21 gram per meter square the density, microporous monofilament mesh was used. And what they did, only the single surgeon performed 225 cases were performed by only one single surgeon. They followed till 1 year and they also found a very good result with fewer complication and lesser chances of recurrence of prolapse. So This again, the study was measured long-term outcome of anterior apical mesh shear lift versus anterior colporrhaphy and sacrospinous ligament fixation and advanced pelvic organ prolapse. Basically, mesh with the native tissue repair was studied. This was again in the Taiwan. The mesh was used was of Germany, shear lift, and again in this, they were the equal 98 and 83 patients were taken for the study. Better outcome was found when the mesh was used, and the mesh had the proximal and the distal arm, middle arm were cut, and they were properly inserted. The mesh was lightweight, macroporous, monofilament, and compatible, biocompatible. But it was there, and it has the fixation similar resemblance of this. So this has the better outcome as compared to the native tissue repair. Yes, this is interesting. This I want to say. This is a very short study of only 25 cases were studied in this retrospective case series, which was published in Jan 2025. And it was a long-term outcomes of laparoscopic sacrohysterectomy for the uterine preservation. Mean age of the patient was 44 years. Slick mesh, which has the tissue mesh, polypropylene mesh. Along with that, it has a textile implant also. It is biocomposite mixed with both. And this has the density of 46 gram per centimeter, more than it was not ultra lightweight, but it has the resemblance of the nature of high uterosacral ligament suspension. The uterosacral, it resembles uterosacral ligament. It was very tough. Again, in this study, what they did is fixation, as we see the sacrocolpopexy or the sacrohysterocolpopexy also. Hysteropexy, when we fix it to sacral promontory, we have seen the complication as discitis. So they have reduced incidence of this because they have soft tissue fixation. Again, which one more technique which they modified in this was they had, as we know, the mesh, even if we do it abdominally, either laparoscopically or robotically, we have the chances of exposure because it is not properly peritonized. So to enter the peritoneum, they have a special devised trocar, which they insert through laparoscopically direct entry. So that is also there. There's soft tissue fixation. So there are less chances of complications. So this all has been avoided. And again, they found a good result. But yes, this all mesh studies has a shorter follow-up duration. 1 year to 5 years were the follow-up durations of all the studies. So basically, what at this short as this, so what I read is I came to the conclusion of this all when I got through a lot of articles. In this, whenever they know of the studies, they have used mesh posteriorly. So posteriorly, there are high complications if the mesh is used in posterior repairs. One thing, all have done anterior, and they have done anterior route through the sacrospinous fixation. As we all know, even if we do the posterior route for the sacrospinous fixation, there are high chances of recurrence of prolapse in the anterior compartment also. And the anterior, when we go through anterior sacrospinous fixation, the recurrence is less. So again, this mesh was used that. So that may again one more criteria may be there for the better outcomes. Surgeon experience, they have always mentioned that in this case that when the FDA ban was there at that time, the surgeon experience, they were not trained that, as we say in the last, there were very few percentage of surgeon who were actually trained to do these procedures. So that is learning curve is important. Surgery case selection is important. They did the proper case selection. Usually the patients were of menopause age group, and when they did the abdominal, they were young patients. This is there. They gave the post-op Evelon cream was there. So these are the small things which were there, and it's revolving the tissue. Like it even for the SUI surgeries, we see what the Abrivo tape is there. Initially the TOT tape is almost 18 centimeter long, what we use. And when we use the TVTO, that is Abrivo, it is only 12 centimeter long. The reason, the advantage of 12 centimeter is it does not pierce or broke the groin muscle. The layers infiltration, the layers which we prick or get the injury is lessened. So there are less complication of groin pain and other complication. So mesh length is important. Structure, biocompatible nature, density. The type 1 is less than 45 gram per meter square. The density should be there. In the few, one of the studies, as I said, it was very ultra light, only 21. these all the features are important when you have to use the mesh. The mesh is not getting all the various studies, various surgeons, they're all evolving the technique how to minimize the complication. And unfortunately, I may not be very thorough with that. Couldn't find any Indian study or long study which we have used vaginally mesh this thing. So I think we need to publish our own data because there is very controversial between the western and the eastern part of the data. They prefer mesh, and the less studies from the US, UK side preferring or going for the mesh thing. So ultimately, take home message are type 1 mesh which are monofilament, lighter weight, macroporous should be used. Mesh is used in transvaginal POP repair and has been reclassified from class 2 from class 3. Transvaginal mesh repair does not conclusively improve clinical outcomes over traditional repair. This has been disregarded. Surgical mesh for SUI, abdominal repair of pelvic organ prolapse remain in class 2. FDA determines serious adverse events related to mesh are not rare, must outweigh risk versus benefit. Even if when we study the long term or the average data of the mesh exposure, when we do for the stress urinary incontinence, it's about 1.5 to 5%. The various studies, they have found the exposure rate around 4%, transvaginal mesh used for the prolapse. So this is also one. So at last, the 4 questions we should be when we use mesh. Why to use mesh? In Japan, the mesh is used very nicely. Germany, Taiwan, Austria, they are using as mesh. So by mesh is always used when you have the last resort. I'm talking about especially for the prolapse. SUI, we use it very frequently. For the prolapse position, the why to use. So we should go all better with our right from the conservative pessaries and our standard. And if there is recurrence, it's always the last preference, not the first. It has a complication. Who should use the mesh? The surgeon. The experience is very matter. Who has been trained with the mesh, who has dealt with the such cases, should be proper training should be there. The learning curve should be adequate to learn to properly insert it. And how to do it, very important. Various studies have described various minute technique which have given them a better outcome. So how you do it, the procedure is very important. And on whom to do it, which patients are fit, like diabetes, immunocompromised, radiation, vaginal mucosa thing, any connective tissue disorders. These are very important. To summarize, mesh is not extinct. It is in use, lighter weight, macroporous, polypropylene, and with a good learning curve experience, and follow-up of the patient is very important. And before everything, the consent of the patient should be aware, informed that this is the thing to be done. So everybody, thank you for the opportunity, and I thank you. Any question? I'm happy to answer.
Thank you, Dr. Mohini. Now we call upon our moderator, Dr. Monica Gupta. Vijaya madam, you can introduce Dr. Monica.
Yeah.
Dr. Monica, slide Chitrakala. Dr. Monica's, yeah. Yes, ma'am.
Good
Madam.
evening, Monica. She's a professor at BMMC Safdarjung Hospital, New Delhi. She's a fellow urogynecology and pelvic reconstructive surgery, special interest in urogynec and critical care obstetrics, chairperson AOGD Urogynec Committee 23-25, and secretary AOGD Foxy Delhi Society 21-22, and Archie Delhi 2018 to 2020, editor ICOG, Foxy ICOG yearbooks, Ops Gynae and National NARCHI Periodical and Foxy Focus, Coordinator of North Zone Foxy Food and Drug Medical Surgical Equipment Committee 18 to 20, Commoner of UA Foxy Orator Award, ICOG Travel Fellowship Award, Datta Foxy Award, thrice for the Best Publication and Textbook and Foxy Focus, Best Young Faculty Award, Vishita Seva Samman for Women Empowerment, Kranti Jyoti Gaurav Samman, Champion of the Foxy Award. No, let me read. You have got so much. Foxy Dheera Award and publications in National International Journal and Editorial Board of Indian Journal of Research and AOGD Bulletin. And reviewer of the BJOG. Oh my God. Jogi, S.A. Fogg, JCDR, Curious Fertility Science and Research. Who else can be a better judge for this topic than Monica? Welcome, Monica.
Thank you so much for the humble introduction, ma'am. And I must say, I'm so happy to be here at this forum, at the same time enlightened by the quality of discussion we've just had. And I'm really thankful to you to make me part of this, and making the moderator of this wonderful discussion, in which we had wonderful presentation from Raghavi and my dear own junior Mohini. And I must say, there is practically practically nothing left for me to actually be telling about what we know about meshes. But yes, maybe one or two nuances which I can add for the way forward with the for the topic which has been given to me. So the disclaimer is that I was not knowing that I was about to make some presentation. I was about to basically be moderating their debate. But they have done such a wonderful job that practically, both of them have said both the pros and cons of practically all the meshes being used. Raghavi did a wonderful job telling about the basic, the biomechanics of all the meshes, what every gynecologist, every urogynecologist should know before even attempting to do a mesh surgery. And Mohini very beautifully had put out that yes, meshes are not extinct, and we should not be, thoroughly
Afraid of.
in the West. Yes. So my job is left just to kind of reiterate the finer points which both have made. And let me see how I can take you through this. So just allow me to share my slides. Um,
Chitrakala.
can you see them?
Yes, ma'am.
Yeah.
Yes, ma'am.
Make it
Yes,
visible.
ma'am.
Okay. So, having heard both wonderful speakers, let's see regarding mesh, what is our way forward? So, as has been beautifully put out, the controversy on the role of mesh in vaginal pelvic floor surgery is actually underpinned by an apparent disparity between the scientific evidence and the real world data, highly influencing the public opinion. Mind you, the huge controversy which happened in UK, and I have been partly witness to all that during my fellowship time in UK, when there was this huge public roar against meshes. There were many groups which were formed, and the patient groups, social organization groups, everybody talking about the complications of mesh, and hardly few people talking about the actual benefits. And even in UK, there were a group of people who had actually used the mesh repairs, especially for incontinence surgeries. They were great proponents of the surgery. And in every forum, they used to discuss that, yes, these are the potential benefits which should not be ignored while just blanketly saying no to the use of meshes. And we actually started talking majorly about all this when the thing spread to US. And yes, in April 2019, FDA banned the sale of vaginal mesh kits, which came with a bang. All these Epo-G, Peri-G, all these things were, even we had started using all those things, and it was being shown rampantly in all the conferences, and they were showing good results. But then UK and Australia had banned them earlier itself, but anything which is done majorly by FDA gets projected farther and wide. Now, the reported complications, which have already been told, but still I would like to make mention why at all these things happened, was exposure into vagina, erosion into viscera, mesh contraction and painful bands, pain and dyspareunia, defecatory symptoms, granuloma formation, visceral injury, and fistula formation. Now, all these complications, when the patient would report, the operating surgeon or the institute would face a huge amount of lawsuits. And that was the one thing driving towards the ban of these mesh surgeries. Now, having ignored probably the surgical skill of the operating surgeon, the learning curve of that, and maybe the large benefits which have been there existent till date. But then again, a thing to notice, with both our previous speakers have said, this mesh ban was not applied to the transvaginal mesh being used in the treatment of stress urinary incontinence, or to transabdominal mesh used for prolapse repair. So for all those who are listening and part of this wonderful debate being going on, they should note that all the controversy was majorly because of the transvaginal mesh repair being done for pelvic organ prolapse. So one thing should be very clear. Also, the same time almost, there was a 2017 consensus of European Urological Association and Urogyne Association saying that use of synthetic mesh mid-urethral slings for the treatment of SUI had good efficacy and acceptable morbidity, which is part and parcel of any other surgical procedure we witness. And also all available treatment options as well as the benefits and risk of each should be discussed with the patient prior to making a treatment decision. This was also one of the recommendation being given in the consensus statement. Having heard all that, there were a few papers which have been multiply quoted by people world and around, by Chris Maher, who had published in 2013 and 16 saying that there were around 18% erosion rate for vaginal mesh, but at the same time, especially for anterior repair, mesh gives a more lasting result, which even Mohini had highlighted. Okay, so all the things combined together, what must be known is that yes, there is a definitive advantage of over native tissue repair for these meshes, because both subjective and objective improvement increases leaps and bounds with the mesh repair. Also, especially in anterior compartment, and also for the elderly with comorbidities, who cannot undergo prolonged surgeries under general anesthesia, can just be offered regional anesthesia. This is one very good available option, provided the surgical skill being used to apply that is appropriate. And also, at the same time, if a mesh is applied for pelvic organ prolapse, it can cover both apical, anterior, and posterior compartments. That should be made a note of. So, should we follow some countries in the West and abandon the use of mesh? This is the way forward. Now, what we have to think as surgeons, in the entire country, we as association in India and maybe South Asian countries, we need to come together and discuss this out. One such instance was in 2019 in Nashville conference of IOGA, when a Pan-Asia workshop was held, and it had participants from Japan, Taiwan, Malaysia, Singapore, and India. And the discussion trend was not to abandon, but to use the mesh carefully. And even to the extent that Asian countries should come up and manufacture their own mesh, as the American companies were withdrawing the mesh kits that time. So, thing to ponder would be, if vaginal mesh for pelvic organ prolapse repair has advantages, can we take steps to avoid the complications and continue to use mesh safely? Because that is what everybody wants. Surgeon wants less of complications, less of seeing the patient again and again, and improving upon the particular surgery already done. And the patient wants a surgery which gives a good, subjective cure. The bothersome symptoms are decreased, and of course, a reoperative rate is always reduced and facing less of complications. So the precautions to be taken, if at all mesh is being used in future from now on, what all must remember is we have to use macroporous soft propylene mesh. A full thickness dissection of vaginal wall is a must, so that the mesh is laid deeper into the vaginal tissue, and the possibility of vaginal mesh erosion and extrusion is decreased. Also, the placement should be tension free, and preventing rolling and bunching of the mesh, whether it is an SUI mesh surgery or a surgery for pelvic organ prolapse. And adequate anchoring with non-absorbable sutures is the key to let the mesh be in place. Now, here I am quoting this example and a mesh being tailor-made and initially used by our own, master of the master surgeons, Dr. Piley, who had used this mesh initially tailor-made with extremely soft central core, but not so soft macroporous mesh for trails. And these trails, which you can see on the top and the bottom here, this was anchored, these two were anchored anteriorly to the obturator fascia, and the just next to the the pectineal line, and this one was taken to the bilateral sacrospinous ligaments, and posteriorly to the sides of the lateral margins of the perineal body. Thus, an anchoring in the entirety of vault, specially used for vault prolapses. was done by him. And he had also advocated use of reusable trocars for deep placement of the mesh and use of non-absorbable sutures for placement of the mesh. Later on, through his own surgeries, he had tailor-made this mesh to something like this on your screen, where these two extensions were the anterior ones. This was the apical support, and this was the posterior support. So he did away with the tailored long edges, which were not that soft enough, and used in entirety the soft macroporous propylene core only. And he has shown to have real good results. Moini just mentioned that there has not been Indian study. Yes, probably sir will be publishing long-term results. I mean, but it's a very good thing to be shown. He had presented sometime in an IGE conference a result of around 107 patients who were very nicely benefited, and hardly a rate of 1% complication in that. So future considerations, we must know that, although data have shown consistently high success rates, more data is needed to better understand the risk factors in surgical complication, and especially from our part of the world. All those surgeons who are listening and have had experience of use of mesh should probably bring forth their data, so that we can have a combined registry and our part of world data and results out there in the Western world as well, to show them the comparison. And the current litigious atmosphere as such threatens to derail any further innovation and progress in the use of synthetic materials, especially coming from the Western part of the world, to treat the growing number of women who suffer from pelvic organ prolapse. But at the same time, we must remember that there are innovations existing, as I have just shown you, coming from our own great Indian surgeon. As providers, it is our responsibility to continue to educate patients and separate the fact from fiction regarding the use of transvaginal mesh. And the paramount thing is that the mesh use has to be regulated. How? Proper training and mentorship of surgeons is required, and they should be insisted to do that before giving them permission for vaginal use of mesh. That is a wonderful way out, so that we know that there has been a certain amount of, the learning curve for the surgeons opting for vaginal use of mesh. And of course, a holistic approach that includes procedure, host related factors, and the mesh itself, which will be the key in considering the interplay between all these factors and reducing the further unfavorable outcome in relation to pelvic mesh devices, which are supposed to be used in future. Alternative way out, yes, we have seen world over and in our own part of the world, there has been a renewed interest in non-mesh alternatives such as colpo suspension and autologous native tissue slings, where we are using the patient's own native rectus sheath sling, or the tensor fascia lata being used both vaginally and abdominally. And of course, having said all that, with this polypropylene controversy going world over, there have been newer materials which are being now explored, as polyvinylidene difluoride, which is PVDF, and polytetrafluoroethylene, which is PTFE, in making of meshes in the future. And they are potentially safer alternatives to polypropylene due to perceived better biocompatibility, which was in fact beautifully explained by Raghavi in her talk. And yes, that is the future which I had to tell, maybe a reiteration only, but we all should be wary of these facts. Thank you for patient hearing.
Thank you so much, ma'am. Thank you. Extremely clear and lucid presentation. Vijaya madam and Dr. Meena. Vijaya madam.
See, the only thing is, are they using any other? She was telling about MIPS, minimally invasive pelvic, like that through the vagina. Is it, what is that one? For fixing the mesh, is there any other technique is there? Mogini was telling MIPS, minimally invasive pelvic.
Can you come in?
For fixing meshes only there, vaginally they do it, anterior vaginal incision, and they fix it to the sacrospinous ligament with the KPO device. In the laparoscopically
What?
abdominally, they
No, no,
use
what
one
device?
material. Yes, no.
Excuse me, what device vaginally?
They use the camera.
Vaginally is the same
Madam.
mesh.
Do
Have
you use
a
any
different
tackle?
material which you use composite mesh and the textile material that they use to, in 25 cases retrospective case series, and in that they have used it.
What is
It
this?
is from
We didn't.
Germany.
What is that?
No, the mesh.
Material,
Ma'am,
Mohini.
name is
Ma'am is asking
Surtax.
for the
Name
material.
is Surtax, and the material is mesh plus some textile implant. This they have mentioned in this way only in the study.
Are they
It is
using
25
cameras?
cases has been done.
Oh, vagina, laparoscopic sacrocolpopex.
Yes,
They use
yes,
catheters, no? So are they using it vaginally?
yes. Something else. No, no, vaginally they are not using anything.
So that's the thing, na. Dominally, though, anyways, even the other meshes have been,
Sorry,
there
madam.
is much less
Sorry, madam.
controversy regarding them.
Sorry, எனக்கு time ஆயிடுச்சு.
Meena,
Meena,
Hello, madam.
yeah, would you like to add few points?
Yeah,
Or
yeah. Yeah, all the points are very much covered by Dr. Raghavi, Dr. Mohini, and Dr. Monica. As already told in the Pan Asian conference, which Madam had taken the session, Professor N. Rajamaheshri, Madam, very well emphasized on the fact that we have to use mesh only when indicated, especially for cases of abdominosacrocolpopexy, whether being a laparoscopic or a robotic route, and also to re-emphasize on SUI procedures where we are using the mesh for TVT and TOT. And as said by Dr. Monica ma'am, we are going to use mesh, the indigenous mesh as devised by our Pelisa. Just wanted to say the same thing, ma'am. Everything very well covered, Vijaya ma'am and Dr. Karpagam. Thank you, dear faculties. It was an excellent session indeed.
what I want to tell everyone is the students are not trained in urogynec. And now that there are not much urogynec, we can just name it or count it. So maybe even the prolapse is reducing because of the primary section. I don't know these vaginal surgeries, and after laparoscopy has come, no one knows the non-distant vaginal hysterectomy. We are really worried about this prolapse the cases. Who's going to manage after Raja Maheshwari ma'am? Now we know only Shikala and Meena here and Meera, three people only. So Raghavi has gone to down south and you people are in north. Maybe around 10 or 15 only throughout India. It's really a tough for the postgraduates. I really feel bad because so much of controversy in the mesh and especially sacrospinous ligament fixation is very tough.
Yeah,
They don't
it's
know.
not easy nut to crack.
Not an
We
Yeah.
easy
have a
one.
cameo here.
So it's very, very tough. At least laparoscopy, they're doing it very nicely with the help of tackers. Just fix it with the pre-sacral fascia and come out. And this is what I am really worried. Maybe the day should come, the mesh should be redefined and it should be redesigned so that everybody it should be easy to use, like a Ensor clutch. How people are very well versed in Ensor clutch, maybe the day should come. That's what I'm feeling, Dr. Monica.
Maybe even 2 or 3 people listening to this talk which we've just had, these talks, and if they can take up, the challenge of learning vaginal surgeries, because there has to be a benchmark where we can say that this is the limit of laparoscopic surgeries, this is the limit of abdominal surgeries. Beyond this, a good outcome cannot be given to pathologies like, long incarcerated prolapses, huge prolapses, vault prolapses, patients not fit for abdominal surgeries, long procedures. I guess there has to be a benchmark, and that is where the expertise comes in. They should know when not to touch the patient that way and send and refer the patient for, but at the same time they should know and witness these surgeries till the time they can.
Very, very nice.
I
Yeah.
think we
Yes,
should never give up the art of vaginal surgery. So
of course, of course.
that is the big
That's a natural
that we are
orifice
facing.
route.
Yeah, yeah, yeah.
That,
Whatever it is, our orifice, our route is vagina. So we should just learn the art of the vaginal surgery and keep up the
Absolutely,
skills
absolutely.
skills forever.
Yeah.
Thank you so much,
Yeah.
everyone. Thank you, Dr. Monica, Dr. Mohini, Dr.
My
Raghavi.
student Raghavi is trained in urogynecology. Very nice to see young people coming up and surpasses the teacher It's really
Did a really
And
wonderful job.
it is a proud moment, madam.
Very nice presentation, Raghavi. Very
Yeah.
nice.
Yes,
Very
yes.
proud moment.
Thank you so much, everyone. It was really nice. And
Thank you. Dr. Mohini, I would like to state here that this is a recording. It will be in our YouTube. So it's not about these 10 participants.
yeah,
It will
yeah.
be played live as well as it will be recorded. So those who need it, along with the topic, they can see it. So it will reach a wide number, that is around 1,300 Oxy members.
Yeah,
So I
That
just
is
wanted to
very
convey that.
wonderful.
Yeah,
Yeah.
you can also share this.
Also, Meena, we should call all of them for our conference, and this debate also can be repeated. It's a very, very
Yes,
good
yes.
topic, and with Dr. Monica as a judge.
Yes, ma'am.
Yeah. No, sure, madam. And definitely you can also share the YouTube, ask your people to read Oxy websites and Oxy YouTube
Yeah.
channel. It'll
This was
be
a
all
wonderful
our
link,
link
I
you
must
can
say, and
ask
all
them to-
postgraduates should know this.
yeah. Vivaadham series recordings will be there. Whenever they find time, they can go through it and learn it, madam.
Okay. Thank you.
Thank you so
Thanks
much.
for having me here. Thank you.
So much.
Tell
Thank you.
something.
And also would like to add to Vijaya ma'am, we do have madam trained so many people, as madam has already mentioned few names. We have the Sita Lakshmi madam having established Urogynec department in the Savita, and Tamil Selvi madam, and Dr. Lily ma'am, Dr. Lalita ma'am. So many people have just
Yeah.
gotten, and happy to see Raghavi, our own, as madam has rightly told, we do have our own students taking up the department.
MCA should have at least 6 months of Urogynec postings.
Yes, yes, ma'am.
We used to have 1 month, ma'am.
You were there. Yeah, Raghavi.
Yeah, madam correctly said that. Yeah. Thank you, ma'am.
Thank you so much. Thanks all
Thank
the
you.
faculty and delegates who have joined. And the